All right, let's go with Chapter 13, Delirium and Dementia. So delirium, the definition is short-term confusional state with sudden onset, typically reversible. It's also referred to as an acute confusional state. So it's short-term and sudden onset. It's characterized by disturbances in consciousness that impair a person's awareness of the environment, may have difficulty focusing or paying attention, so they're easily distracted. Impaired recent memory is common, along with disorientation and some language problems. They may need to remind patient, you may need to remind patient that they're in the hospital if they're hallucinating. Confusion is a symptom experienced by various patients under varying circumstances. Older people sometimes experience confusion as a first symptom of a disease. So let's go on. So speech may be slurred and disjointed with aimless repetitions. They may misinterpret what is going on in the environment and may develop delusional thinking and experience hallucinations. They may have irrational fears, such as, well, a person may think that the banging of a door is a gunshot. So they're distorted thinking. Delirium may alternate between hyperactivity and hypoactivity, may fluctuate from drowsiness to stupor or coma. Conversely, may be alert and agitated. Other symptoms that they might experience would be anxiety, depression, irritability, anger, apathy, which is they just don't care, or then the opposite, euphoria, where they're feeling really good. So an acute confusion begins abruptly and usually lasts a short time, maybe as long as a week, but rarely more than a month. Now, mild neurocognitive disorder. It's a modest decline in cognitive function. Individual functions well enough to live independently, but may exhibit apathy, sleep disturbances, hallucinations, and anxiety. The nursing interventions are focused on coping with impaired memory. Develop strategies to aid in memory, such as maybe dividing the pill containers into separate Monday through Friday or Sunday pill containers because they can't remember from day to day. The other thing you might do is make to-do lists. Help them remember, first we'll get up, then we eat breakfast, so it aids in their memory on how to get through the day. Now, there's a major neurocognitive disorder that your book talks about this on page 205. So before I go on to that, if you'll notice box 13.1, it does mention some systemic and central nervous system causes of delirium. So I'd like you to look at that. It lists infections, cardiovascular disease, metabolic conditions, electrolyte imbalances, sepsis can cause it. And that's one thing, like if you notice that your patient is suddenly delirious, maybe they're suffering from an acid-base balance. Maybe they have COPD and they're retaining CO2. Or maybe they're septic and they have pneumonia, massive infection. Maybe they've had a TIA. So be sure that you look into what's causing this. So that's box 13.1, page 204. Then we'll move on to this major neurocognitive disorder. It's chronic and irreversible, as opposed to delirium, which is short-term and reversible. The memory impairment and many other cognitive deficits, impaired intellectual function, problem-solving ability, judgment, memory and orientation, and inappropriate behavior. So if you look at table 13.1, it has major neurocognitive disorders, subtypes. For instance, Alzheimer's disease. That's a form of dementia or a form of a major neurocognitive disorder. Now, Alzheimer is chronic, irreversible. There is no cure. There is medicine that helps them, their symptoms not come through, but if you look through on table 13.1, look under Alzheimer's, you can read about the usual features: insidious onset, gradual, slowly progression. And then the final stages marked by gait disturbances, dysphagia, incontinence, muscle spasms. Patient becomes mute and totally dependent for care. And then another one is the frontotemporal lobar degeneration. You can read through that. That's also an insidious onset. Lewy body disease, insidious onset and gradual progression. So that is cognitive symptoms appear about the same time as motor symptoms. They're very sensitive to antipsychotic meds. Another one would be vascular disease or vascular dementia. The onset is related to a cerebrovascular accident like a stroke. Primary decline is a complex attention and executive function. And then here I have listed Huntington's disease and Creutzfeldt-Jacobs disease. So we had a patient with the Creutzfeldt-Jacobs disease. Now that's also commonly called mad cow disease. And you really don't know you have that. The doctor has to go by symptoms until they pass, they die, and they can do a brain biopsy. That's really the only way you can see Creutzfeldt-Jacobs disease. Parkinson's disease, insidious onset and gradual progression. So you can read through that. Those are major neurocognitive disorders. Now, the cause of Alzheimer's is unknown, but it's usually brain, includes deposits of amyloid, neurofibular tangles, and a deficiency of acetylcholine. So the medication would be related to that. Other conditions associated with dementia: normal pressure hydrocephalus, subdural hematoma, brain tumors, neurosyphilis, and acquired immunodeficiency syndrome or AIDS. Dementia is not a disease, but a clinical syndrome, collection of symptoms that can occur with many types of diseases. So they mostly go by symptoms. Vascular dementia results from damage to brain cells caused by inadequate blood supply. So delirium versus dementia. Determining when confusion started, that's what a nurse should do. So when a patient comes in, you want to find out, when did the confusion start? What happened? And when did this start and how did it start? And whether it has been constant or intermittent. And that can help differentiate from delirium and dementia. The assessment data helps the physician determine if the patient is suffering from delirium or dementia. And if you look at table 13.2 on page 207, it does talk about clinical features in delirium and dementia. I'm going to be pointing you out to tables and boxes. That's really important in this book, and it's very, very helpful. So, causes of delirium: certain medical conditions, substance intoxication, and this kind of goes back to the delirium section, talking about causes. Substance intoxication, so let's say a meth addict might come in intoxicated. It could be with alcohol. Same at the substance withdrawal. So they can come in intoxicated and be like that. And also as they withdraw from alcohol, opioids, cannabis, sedatives, or anti-anxiety drugs, they can also exhibit delirium symptoms. Some poisons. I once had a patient trying to overdose on fertilizer, liquid fertilizer. Ugh. Anticholinergics have been found to cause delirium among older persons, like antihistamines. So sometimes antihistamines over the counter cause delirium. So a family member may come in, and remember, some patients don't remember the meds that they take over the counter. They don't really consider them medicines, so they might not tell you. So be sure you ask about over-the-counter meds. So medical conditions such as liver failure, kidney failure, and hypoxia can lead to delirium. Also fluid or electrolyte balance, withdrawal from substances such as barbiturates, those can all lead to delirium. I'm sorry it seems a little repetitive, but important. So on page 206, it talks about assessment of the patient. So the first step in collecting data about a person with a neurocognitive disorder is to observe the behavior and to collect data about their mental status. So that's very important, observing behavior, and collect data about their orientation, their memory, their sleep habits. What if they're sleep deprived? Family can provide information that the patient cannot. Ask whether the symptoms of confusion started and ask when the symptoms started and whether confusion is constant or intermittent. List acute or chronic illnesses and all medications. Be sure you include home remedies and over-the-counter drugs. I know, it's a little repetitive. Assessment data helps physician if the patient is suffering from delirium or dementia. And this refers you again to table 13.2. So some interventions on page 208 for delirium. Impaired cognition. Communication should be simple and direct. Be calm and reassuring. The lighting should be soft and diffuse to avoid shadows that can be misinterpreted. I want to tell you a little story here. I was once in the hospital for pneumonia, and I was on high doses of steroids, and I was delirious. And a friend of mine came to visit and came through the curtain, but because the lighting wasn't right, he looked like Charlie Brown. I was hallucinating. Anyway, it was a friend of mine too, and I called him Charlie Brown. Charlie Brown, what are you doing here? And then I realized who it was, and I was kind of embarrassed, but just goes to show you how things can be misconstrued. So also remember that patients who normally wear hearing aids and glasses should be encouraged to use them so they can see and hear well. Sometimes a clock and a calendar can help orient a patient with delirium. However, they must be in a place where they can be seen easily. Also, if they have a sleep disturbance, warm milk can help, a back rub, a soothing conversation. They have a potential for injury, so be sure you put their bed in low position. And if they're confused, you can always take them to the nurse's station, put them in a wheelchair, and come sit them at the nurse's station so that they can begin to get reoriented, and also you can keep an eye on them. Sometimes a family member needs to be called and they can stay with them. That's very helpful, and it's very calming to the patient. So some interventions with dementia. Now that's on page 209. So impaired ADLs. So they meet, so their ADLs should be divided into tasks or individual steps, like let's put your shirt on and we'll put it on the right sleeve. Now let's put on the left sleeve. So very clear directions. they can get really frustrated easily. So it's kind of like a child. So if a child gets upset with, you know, something that you're trying to do, you kind of leave it alone for the minute. You don't want to force them into doing anything. Just kind of leave it alone for a minute, and they'll forget about it, and then you can come back to that ADL or that task that you were trying to do. Inadequate nutrition. So finger foods is really good, something that they can just feed themselves. They should be high in protein and carbohydrates. So frequent small meals is really good. And that's really important, and it's a good goal for patients with dementia. Also, patients with dementia are disoriented and their thinking ability is impaired. So you may have to do reality orientation with delirium, but with dementia, it might upset them if they say, "Where am I?" and you keep going, "I told you you're in the hospital." We don't want to upset them. So, inability to communicate effectively, reality orientation may agitate. So that's that. "I told you you were in the hospital. You're in the hospital." "No, I'm not. Where's my husband?" You know, they keep going on with this conversation. And it can get irritating as a nurse because they keep asking the same thing over again. But you can avoid those confrontations and confused patients. So guidelines for working with patients with dementia. Well, they usually forget things relatively quickly, which can be a good thing or it can be a bad thing. Be a good thing if they're trying to get out the door and they remember 1 minute how to get out, and then they quickly forget how to get out, and then they can't get out again, like especially if you have a lock on the door if they're at home. But they're usually unable to learn new things also. So you might have to do the same thing over and over again. You can be creative in the care of patients with dementia by using these two concepts, and that's they forget things and they're unable to learn new things. Sometimes agitation can also indicate pain, hunger, stress, fear, or the need for toileting. You can divert their attention really easy, again, very similar to children. And you can eliminate unrealistic expectations. That's what you need to do. So don't think that they're going to do a whole lot in one day. It may take time. And again, break everything down into individual steps that can be performed. And remember, we want to give them some finger foods. Let's try a question. This is a pretty short chapter, I think, isn't it? A lot shorter than the last one. So question 1, blank is a syndrome that is chronic and generally considered irreversible. It is characterized by impairment in memory accompanied by many other cognitive deficits and leading to impaired activities of daily living. So I'll give you a second. So the right answer is C. Dementia is a syndrome that is chronic and generally considered irreversible. It is characterized by impairment in memory, accompanied by many other cognitive deficits, and leading to impaired activities of daily living. Question 2. Characteristic changes in the brain of a person with Alzheimer's dementia include all of the following except So the answer is D, inadequate blood supply to the brain. They do have deposits of amyloid, neurofibrillary tangles, and a deficiency of acetylcholine. The cause of AD, Alzheimer's dementia, is unknown, but characteristic changes in the brain include the amyloid, the neurofibrillary tangles, and the deficiency in acetylcholine. And that's a chemical that translates the signals in the brain. Okay, thank you.